G'day and welcome back to the BroomeDocs podcast. And it is December 2024 and it's almost Christmas time. So it's that time of the year when I'm going to say Merry Christmas to my good buddy Justin over there in Canada. How are you, mate?
Doing, I mean, as good as can be expected. As I was saying, it's not just Christmas time, but flu season here, and it's been a hard one. You know what it is, kids in daycare, and the viruses go back and forth. And just finally this week, it was like, oh, we're gonna get a good night's sleep, and you get the 3 a.m. vomits. You're doing like laundry at 3 in the morning, and yeah, it's been a long slog. So normally, I think we've been over how we do this, but like I read these papers, back in October or September. Then I send you an email with them, and then we try to arrange a time to record. And because we're on the opposite sides of the world, it takes a while. So we always have these excuses, but like I read these 2 months ago, and normally I try to like re-prepare. Yeah, I'm a little less prepared than usual. So we'll see. We'll see. I'll let you carry the load of the intelligence this morning, which you do every single time anyway, and we'll see how it goes. I guess not sure morning for me, night for you. I don't know. This is very, very confusing as always. But how are things back there in the beautiful summer of Perth, Australia?
It's very nice, and I've just had a couple of weeks off, so I'm not going to complain at all about viruses or work or anything. So I just had an amazing holiday over in Indonesia, doing a bit of scuba diving. So that was awesome, and it was awesome. It was a beautiful place, but I had the very nerve-wracking experience of taking my 3 boys, and they were learning how to scuba dive and parenting at 20 meters under the sea. You've only got a certain number of hand signals, and you're not allowed to actually strangle them under the water. But they can. Teenagers are. Let's just say that their brains were writing bigger checks than their lungs were potentially able to deliver. So it was a little bit nerve-wracking as a parent, because if they do something stupid at 20 meters, the consequences are a little bit higher, unfortunately. But we made it through, and they had a great time and learned a new skill. So good times.
Yeah, I would not want to have looked after me as a teenager. I remember now, like when we did snowboarding when I was a kid, nobody wore a helmet or anything. And I remember my mom watching me go off these like 40-foot jumps. I mean, like, what are you worried about? I'm fine. I've never died before. Yeah. I feel like that was my motto. I've never died before.
To give you an example, my middle son's probably the worst. Like, to get to the beach from my house, we have to walk across this sort of double lane traffic highway, and whenever I go down there, he always takes off to walk across the road, and I grab his hand and pull him back and say, "Hey, there's a car coming." And his answer to that is, 90% chance I would have made that.
We might get into that. Actually, I think next month is going to be more than this, but yeah, I think some people use stats and numbers a little bit differently than you and I do.
Anyway, cool. The only interesting that actually happened was I had an in-flight emergency on my trip back home to Australia just a few days ago, actually. So, and it made me realize a couple of things. One is, we're reasonably impotent as emergency doctors when you take us out of our environment and give us zero equipment. So, I was on a plane, and there was an emergency, and my wife volunteered me to attend the emergency. She is also a doctor, but she was watching a movie and had a few drinks. So good on that. And so I went to this emergency. A chap was having a seizure, which, that's bread and butter for emergency docs, and it wasn't too bad. Like, it had stopped pretty much by the time I got there. And I called for the emergency medical kit, and they only had one medicine on the plane. Do you want to have a guess as to what it was?
I mean, one medicine has got to be an EpiPen, right? Or maybe aspirin. Those are the 2 things that would make sense to have on a plane.
No, it was ammonia smelling salts.
Something I've literally never seen in my life. I think maybe it was cool in my high school to carry those around for a little while for some reason. I don't know.
I was looking around like, is it 1842? Like, what's going on here? And the stewardess was quite offended that I didn't want to take the ammonia smelling salts and use them, because I didn't want to enter into an evidence-based discussion at that point, but it seemed like a bad intervention.
No, it always seemed ridiculous. Ridiculous that they call for doctor's overhead, because like you think about what the average doctor is. But the thing that proved that to me, so I was on one flight where I got the call overhead, and the emergency mindset, maybe we should be sprinting, but like I made sure I carefully got up and didn't knock over my tray table and stuff like that. And so by the time I got back to the back of the plane, there was 14 people there already around this girl on the floor. So I was like, I wasn't even going to say anything. I was getting ready to just turn around. I'm like, this is well looked after, just like you would at a code. Like, okay, there's other things to do.
Sure.
But I figured I'd just be like, hey, I'm Justin. Who's everybody? And one by one, they are all like, psychiatrist. The plane was on its way to a psychiatry consult. I was like, okay, emerge. I'll as everyone back to the seats and fucked off. So the 15th person who got there was actually sort of okay. But like, clearly they should be asking, is there a paramedic on the plane? Because that's the person who knows how to deal with things without the hospital, without the medicines, without anything. That's the only person who I would want coming to me in a plane emergency, unless there happened to be ICU or anesthesia or emergency medicine, maybe. Family doctors or GP, I guess, ruralists are, I guess, pretty good at bloody everything as well. But I don't know. Even if you happen to find a doctor, and I saw some crazy stat that, like, I think it's something like 96% of all flights have a doctor on them because doctors are so rich and travel all the time. But if you happen to find one, like, what are the chances they know what the hell to do in an emergency? It doesn't seem high to me, but who knows?
It was a relatively surreal experience and very unsatisfying all around for everyone concerned. And I got to say, the highlight for me, because I'm a bit of a misanthrope and I appreciate some sort of bitter ironies in life, but during the procedure of supporting this patient, I got vomited on and I had vomit all over my hands, and they didn't even have PPE, which was kind of uncool. And then the steward said, "Oh, you need to go and talk to the pilot about what the plan is." And I said, "Do you mind if I go and wash my hands?" And the row that we were in was just like the row immediately behind business class. So I went to go to the bathroom, and they said, "Oh no, sorry, sir, you have to go and use the toilet at the back of the plane."
Are you kidding me? So the back of the plane, the doctor they had
to walk all the way to the back of the phone to wash my hands, and then I could walk back to the front to have a chat to the pilot.
It sounds like you might want to consider flying with nicer airlines. you might have tried to save a little bit too much money on this one.
It was a very budget airline. Anyway, I won't complain. I wasn't the sick one, so it was all good. Yeah. All right, mate. Enough ranting.
We're talk about some people. Yeah, we're a medical podcast, not just two blokes whinging about things.
Well, you know. Cool. Let's go. So the first trial we're going to talk about tonight is a bit of a do-over, I guess you would say, because back in October we talked about this exact same topic when we discussed the Hemotion trial. I think that was the special episode with the junior doctors presenting from memory. Yep. And back at the time we sort of said, not really sure. It was a trial that sort of had a few questions, but we thought more evidence is required, which we often say at the end of this podcast. But literally 3 days after that, this trial was published. So this trial is the TRAIN trial, and its actual title is Restrictive versus Liberal Transfusion Strategy in Patients with Acute Brain Injury. It was published in JAMA on October the 9th, so literally just after our second last podcast. And so this is a very similar trial to what was done before. The population here included a lot more, once again, traumatic head injuries, but they also included 20% subarachs and 20% intracranial hemorrhages. And they used slightly different cutoffs. Instead of 90 in the restrictive group, they used, it was 100 versus 90, I think was the other trial, wasn't it, for the restricted group? But yeah, that's basically the same thing, 70 being the restricted and 100 being the liberal. And essentially this trial was a little bit different because this one did actually have a positive outcome for something that we actually care about, and that there was a risk reduction I should say there was a better outcome for favorable neurological outcomes in the patients that got more blood transfusion, essentially. So interesting. We asked for more data, we got it, and it may be pushing us towards something which, to be honest, pretty much every other indication for transfusion in emergency medicine, I tend to go towards more the restricted group. I tend to be less is more sort of doc, but it seems like this may push us in the other direction. Justin, you've had a good read and a write-up on this. What were your thoughts?
Yeah, it's such an interesting topic. And as you say, I think one of the big things in evidence-based medicine we try to teach people is you can't just read one paper in isolation. So you sort of have to understand some overall science, and everything seems to be pushing towards less blood. Although you got to be really cautious with that group of evidence, because I have seen people make a mistake because it's less blood, but in not critically ill people. So I've seen some people try to cut back in that should be a massive transfusion protocol kind of patient, and they don't quite get pushed high enough. And those people would always be excluded. So So when everything's pushing you in one direction, it's a little bit surprising. But even with that bulk of literature, people were always saying, hey, let's be careful about, like, the cardiac patients, the people who need good perfusion, and brain injuries would be one of them. This trial, if I was looking at it independently, had a couple things that would make me a little bit concerned. It's a classic trial in that it's unblinded, and the outcome we're looking at is highly subjective. These are neurologic outcomes rated by people who knew what their treatment was. That is classic for incorrect answers in a trial. And then there's just one thing that really bugged me about this trial. I've complained about people setting their sample sizes a lot. And originally, they were looking for a 5% absolute improvement in neurologic outcomes, which is clearly a clinically important outcome. But when they started getting some numbers in, they realized they weren't going to be able to get enough numbers. So they doubled it and they made it 10. Not perfect, but fine. If you know you're not going to get numbers, you at least make sure your math works out. But then they changed it again and changed it to 11%. 11% is just not a number that anybody would choose a priori out of a hat. There's no way that they picked that number. They looked at their data. They had to have cherry picked that number based on their data. And that really, really worries me if this trial was sitting there all by itself. If they were asking for a big practice change or for like an expensive new medication. But if you go back to Himotion was technically a negative trial, but the results were identical to this. It was statistically negative, but we said, hey, look, the point estimates are it looks better with liberal transfusion. And so now we have another one with it looks better with liberal transfusion. And all they're asking us is, transfuse to a level of like 90 or 100. That's 9 or 10 for Americans, which might be a lot of people. So keep that hemoglobin a little bit higher. That's not asking a lot. In fact, I bet you some people would tell us that's current standard care. So I think that, yes, that this is, depends on whether you call this a practice change or just practice confirming, a little bit more blood in people who need it to perfuse their brains. But if I'm setting my certainty here, I'm still nowhere close to 100%. I would not be surprised if there was a big high quality trial in the future that tells us actually this doesn't matter at all, or the results are exactly the reverse, because there are some red flags. But for right now, my target is like 90 or 100 in these brain injured patients. I think that makes sense.
Yeah, that makes complete sense. And I think looking at the secondary outcomes in this trial as well, it was kind of satisfying in that the only region where there was actually a statistically significant difference was actually in the rate of cerebral ischemia, which is sort of what you would imagine in this setting. Like, that's what you're trying to avoid. You're trying to keep them in that Goldilocks zone where they're getting just enough oxygen to their brain. So that sort of makes total sense. So I think that's pretty reasonable. And you and I don't work in ICUs, so we don't really have to think about this too hard. But at least we have a bit of an idea as to what the targets are. And I think that's pretty fair. They obviously this trial was a bit later than the previous trial, so that's probably the other big difference. Is this one, I think most of them were randomized on about day 3 of their injury or something from memory. So I think the previous trial was a bit more emerge or acute care, but I don't think that the patient or their brain mind, which part of the hospital they're in, the red cells getting to your brain is the important part. Yep. Cool.
Yeah, it doesn't seem like one of the must be done in the first hour kind of interventions, but if you're truly worried about ischemia, and for the most part, I think we should be clear, because this is trauma. Most of the time, this is chronic anemia that they're treating. This isn't like the acutely bleeding patient. And I think that's a mistake you could make. You could think that your target's only 90, C90 on page, but the patient's still bleeding from their pelvic injury. That this doesn't change your management in that patient. But I think it makes perfect sense, assuming that you have everything else stabilized, to get some blood started. If you have somebody who came in with a hemoglobin of 72 at baseline, you go back and check, it was 72 last time, but they're in. And you just intubated them because of a brain injury. This is not the time to be messing around with lower levels, and they're probably going to do it upstairs anyway. So you can do some of the work. And it might improve outcomes. Like these, this is believable to me. Some red flags, but definitely believable.
Yeah, and it's kind of nice to know that if you're in that situation in the ED where you're sort of flying close to the wind with a HB of 75 and you're not sure whether the patient's bleeding or not, whether to give more, it's probably the right thing to do.
Yeah.
Until you get more information. So you're probably not going to do them much harm, though. It's depending on all the other data that you've presented in the past about bleeding and traumatic resuscitation. But one bag of blood is what you need to get from 70 to 90 in most cases. So it's not the end of the world. Yeah.
Yeah, I feel like I think people, when they listen to us, sometimes feel like I'm nihilistic or they get a little bit worried. But one of the nice things about realizing that nothing that we do matters in evidence-based medicine is that nothing that we do matters, which means on those, when you get criticized because you forgot to like start a beta blocker in the MI patient, you're talking about an absolute difference of 1% here. Yeah, if the extra transfusion is going to hurt patients. There's harm, but like in the less than 1% range. So like it gives you a lot of leeway to make some mistakes in medicine when nothing you do matters. It's really nice. I think you want to optimize care as much as possible. And obviously I don't practice with that belief in forefront, but like for the most part, nothing you do matters. Get out of the way. The patients have a good physiology and they're probably going to heal themselves most of the time.
I don't know that you're nihilistic. I think you're skeptical. How's that for a segue?
Ooh, that's very, very good. You're after 10 years of podcasting, you're finally up in your game. I'm very impressed.
So we'll leave that one there and we'll move on to the next trial, which is entitled Skepticism, a Lost Clinical Art. Now, this is a trial this isn't a trial. This is a sort of editorial paper that was written in the year 2000. So this is now nearly 25 years old. So a quarter of a century almost, Justin. So it's a lovely paper. It's well worth a read. But I just got to know, like, how far back does your collection go of sort of airy-fairy editorials? Like, how far back do you go?
Yeah, the problem, and I don't know how we ever do this unless we become professional and get paid, is like every month the number of PDFs I haven't read grows by a factor of like 1,000. But there's like 10,000 sitting there that somebody has sent me, or just sitting there that had interesting names at some point that I haven't read. So yeah, every once in a while I find one of these, and I guess like I don't know why I include this, but I sometimes just get suckered in. And this one, the very first sentence or sentence or two it just so fits with my philosophy so well that I sort of had to throw it in here as a recommendation to read. In fact, maybe I'll read this quote because I think this is great. So, skepticism is generally regarded in scientific circles as a necessary element of healthy agnosticism, less adversarial than cynicism, but much more demanding than faith. Under the weight of solid evidence, the skeptic can move towards acceptance and even evolve, albeit reluctantly, into a true believer. However, in our modern era of unprecedented scientific growth, where significant biomedical advancements are daily occurrences, it appears that contemporary physicians have become more willing to accept the latest and greatest without careful scrutiny. So good. You got me right from the beginning. So this is just an essay by an infectious disease specialist. So some of the clinical stuff isn't, up our alley as much, but just that moves on from there to discuss some of the issues with modern medicine that I think are right up my alley. I don't know. It's hard to summarize in a podcast format. I threw this in there mostly because, I think some of our audience likes to have some things to read. And this is a good one. Over Christmas time, you got a fireplace, you got a warm beverage in your hand. This one is a good one to sort of sit and reflect on your overall practice of medicine. And there are a bunch of things in here that I often use to teach medical students when I have them on shift with me. But I don't know if it covers such a broad swath. I don't know if there's one thing that you wanted to tackle or debate. Was there anything here that like jumped out at you, or would you just leave it as a recommendation? What do you think?
Yeah, I think. Look, I read this paper, and I really quite like the table with those aphorisms that are in the paper. So I think if you're going to like print that out and stick it on the back of the toilet door at work, or in the tea break room or something, so that everyone can just have a read of it on their tea break, because it's half a page of little cute aphorisms that are actually quite profound, some of them, which is really nice. So that's what I'd probably do with this paper if I was a listener to this podcast. Just print out table 1, put it in the tea break room. It's a good talking point for a quiet moment on a shift as well. I did find the meat and bones of it. Some of the examples. This guy's clearly infectious disease clinician who is also obsessed with quantum physics and other really nerdy things. So it's right up my alley. But some of the examples that he uses are so specific and so pertinent to. You can see that he's got an axe to burn, an axe to grind. Sorry, with certain things. Like he really isn't a fan of carbapenems as an antibiotic, and he's written a lot of stuff about that. So some of it's very specific, and you won't get much out of it. But I think the list, table 1, is quite nice and definitely something that you could bring out if you want to do a bit of teaching.
Yeah, I think there's just so many things. I think the one clinical one that I hadn't jotted down myself to here just to mention, because it's worth thinking about, is he talks a lot about how Diseases we treat now were actually invisible to our forebears, to our ancestors. So like the osteomyelitis that you can only find on MRI, or the endocarditis that we only find with transesophageal echo that would have not been diagnosable in the 1980s. And how unfortunately, like that's great. It's great to have better diagnostic tests, but you can't just automatically adopt the treatment from the old times to these new diseases, which are completely different without any science. And that's what we tend to do. And I think the emergency department example that we always use might be subsegmental PE with our high quality CT scans or things like that. But it's worth thinking about how the definition of diseases change over time, and how our treatments don't necessarily change, or how we basically say something is standard of care, not recognizing that we've completely changed which population we're applying that treatment to. I thought that was a really interesting insight that we sometimes lose track of, worth thinking about.
Yeah, no, absolutely. And I just presented a video yesterday looking at, the classic is aortic dissection, and now we're finding these things called penetrating ulcers, and are they like, do they need treatment? Like, did we know about them in 1987? Were people just rocking up to the ED with chest pain, and so we're saying, oh, your ECG's fine, go home, and they did fine. So we're finding more and more examples of these sort of sub-diseases or preclinical diseases, which, maybe we're potentially doing more harm than good, and having better tests, as you say, we need to adapt our strategies and our treatments to meet those criteria. And it's very hard in the modern era as well to say, you'll be fine and go home, because that's just not the way that modern medicine is practiced, particularly in your continent.
Yeah, it's really, really, really tricky. And I wish I could be one of the old school docs, but it's just, it's really hard. But it's also hard because a good percentage, we know that medicine was not perfect in the 80s when it was just, you go home and you're fine, or our best test for your MI was like an LDH or whatever they were using back in the day, right? Like it's like, so like there is our tests are very good, and they're very good for a reason. But, obviously we've talked about overdiagnosis and all the other problems many times before. And so there are a lot of things that we are doing that, which maybe at best they're futile. At worst, we put a label on somebody forever and they get some harmful treatment. But yeah, I like this essay a lot. It's maybe my favorite of the month, but for anybody who's listening to us for clinical information, it doesn't get you very far. So maybe speaking of futile, we can move on to, we have a pair of papers that fit very well together: IV versus IO in cardiac arrest.
We seem to be repeating over recent territory, because I know we talked about another trial last month with the exact same intervention. So
yeah,
go for it, man. Tell us all about this.
For that time, right? This is now. So we were covering the gamut. IM, IV, IO. This was exact same as the head injury. Actually, I just finished recording a podcast for EM cases, and I think we just finished recording the IM, and then both of these were published. And I'm like, that would have been nice information at the time we discussed this stupid IM idea. But yeah, so there's two trials, both published in the exact same edition of New England Journal of Medicine in October 2024. So there's the Paramedic 3 trial. We've covered Paramedic 2 before, so this is Paramedic 3, and there's the IVIO trial. Quick summaries is Paramedic 3 is from the UK, multi-center there, 6,000 patients. They were supposed to get 15,000, and both the trials are basically the same. They compared either an IO or an IV as your initial strategy in out-of-hospital adult cardiac arrest. IVIO is from Denmark, again, multi-center, a little bit smaller, 1,800 patients. Same comparison as an idea. They looked at different primary outcomes. So Paramedic 3 was looking at survival as their primary outcome, 30-day survival, and it was identical. Neurologic outcomes were also identical. IVIO was looking at ROSC, and it was identical. Paramedic 3 did find a slight change in ROSC. There was more ROSC and more ROSC to hospital handover, but no change in survival or no change in neurologic outcomes. So to me, that actually might indicate harm. But that's the one point where you'll hear people debate on these trials, I think, because some people think ROSC is a really good outcome. But if you have ROSC, get everybody to hospital, do a bunch of stuff, and they all die anyway, that doesn't sound great to me. So that was the quickest that I can summarize two big, massive, like high quality multi-center studies. What did you think when I sent these your way?
Yeah, I think we said this last month when we were talking about the IV versus IM adrenaline and cardiac arrest. Does it really matter what route you give if none of the drugs work? I think the bottom line is we probably think that they don't. And I think they've proven that here. So if you look at the numbers, neither seemed to do particularly well. There was no difference. So it doesn't matter how fast they get in. A couple of interesting stats that I did pull out of this, which I think are really useful. There's quite a difference in the neurologically intact or the ROSC rates between the two trials, given that they're both high quality services that are doing this. But so the Paramedic 3 trial was done in the UK. If you look at their neurologically intact survival rate, it's sort of 2.5%, 3% in that category, that sort of ballpark. And in the Danish trial, it's up around 8-9%. So 2 or 3 times better if you think about it. The big difference between the two is the rate of bystander CPR. So I think if you're going to spend money in the future on your chain of survival, bystander CPR, not adrenaline, is the way to go. So I think that's the bottom line I could take away from all of this, is that an early initial CPR and defibrillation is probably the thing that's going to make the biggest difference. I think how many more trials are we going to have looking at different ways of giving drugs that may or may not work? I don't know, but it doesn't seem that we're making a big difference with these pre-hospital interventions.
Yeah, it's a project that somebody in medicine truly needs to tackle, because unfortunately there's some areas that just don't deserve more study. They get massive dollars. They're just like endless dollars because they're like pet peeves, or like this is the AHA and they love putting out there. They can make so much money off running these ACLS courses and et cetera. And then some, like every month there's like tons of these things where like, well, this is the first trial ever. It's got 80 people in it, where you really need some high quality research, and it just never gets done. So yeah, somebody needs to, we need somebody at the top, a research czar that actually organizes what trials we're going to do in what order, because right now the willy-nilly approach is a little bit silly. There was 2 other things that I thought were interesting to mention in here.
Yep.
The one thing I really, really don't understand, which could be a major bias in both of these trials, is it's way easier to get an IO in than an IV, sure, right? And both trials were the same. It's about 95% chance that you're going to get the IO in on your first chance, 65% chance that you get an IV in on your first chance.
Yep.
The time it took to give medications was identical between the 2 groups. That doesn't make any sense to me. If you're 30% more successful getting vascular access, and like an IO, were they waiting and like taking their time to find the right dressing and securing it before using it? Like, I don't like when I put in an IO, you do the thing, you do one flush, it takes freaking 3 seconds, and then you use the medication. It should have been way faster to use an IO. And theoretically, that's the only reason people suggest an IO, is because it's faster. So the fact that they gave the medications at the same time sort of negates the entire theory for this trial. And so unfortunately, I think these trials were biased to show no difference. And I think there will be people out there who still have a question, because why was the IO not dramatically faster when they were way more successful?
Yeah.
Just like twiddling their thumbs. I really don't get it. I could not figure out why that was the case. The other thing that I think is more interesting, and is more to your point, or what was my major point as well, which is who cares? The drugs just don't work. Was in the IVIO trial, they had a subgroup, and because they allowed both tibial and humeral IOs in that one, and they compared the outcomes, and the outcomes were identical. So that's nice to know. The outcomes are identical whether you use tibial and humeral IOs. Good, that's a good subgroup. Except they also had a subgroup of that where they did CT scans to confirm the placement, and 70% of the humeral IOs were not in place, and nobody had any idea of that. So you had 30%, sorry, the other way around. Only 70% were in, but you have 30% of your patients who got no medication, did not have vascular access, and you didn't know about it, and they still had identical outcomes to having vascular access. To me, that is the best evidence you could ever have that the medications are 100% useless, because you weren't giving medications in that group. Or I guess maybe it works deep intramuscularly. It's just another way of giving intramuscular. Might be the counter argument to me, but that was a really interesting tidbit to me, which is it doesn't matter if you completely fail. Or you can take it the other way, which is, as much as some people really love the humeral, you gotta be really careful, because we know that it will fail sometimes. That could be the other clinical lesson, I suppose.
Well, fortunately, we covered the intramuscular trial last month, so we know that didn't work either. So even if your IO slips out and goes into your deltoid muscle, it's still not working. that was actually really interesting. I don't think they did the CT specifically to look at it. They were probably just doing it to
Yeah,
look at
they
it.
just like it happened to be. Although I don't know why they would have ever done tibial CTs, and they had a good number of those. So that's weird to me.
Anyway.
Yeah, I don't know.
It is odd, but yeah, I've always felt bad because I've never really placed humeral IOs. I've always just done tibial IOs because that's how I was trained back in the dark ages, and I've never really had a crack at doing the humeral ones. And there was a few trials a few years back that sort of said, "Oh, humeral's better. You get the drugs in faster. There's better bioavailability or whatever." But this trial, if anything, makes me feel quite comfortable just to keep going with tibial IOs, unless you've got a leg amputation or something going on down that way. It seems like a much faster option, and sounds like there's about a 30% fail rate for the humeral ones.
Yeah, I don't know why. So, like in Canada, I don't think I've ever placed a single humeral IO ever. I've done tibio has always been my go-to, and then in New Zealand, I ended up placing I think like 20 in the course of like 1 year, and I think maybe it's just a marker of so in Canada, doctors don't do IVs, never ever. That's just not our thing, and in Australia and New Zealand, often the doctor or the junior doctors do a lot of them, and then there's a lot of IV ultrasound, and so I think nurses are de-skilled as compared to here. And so like in these really bad traumas, and we were, I guess partly also I'm a community hospital here and we were a trauma center there, but people who needed vascular access fast or things were happening and things like I had a bunch of people who were like injured in the legs or like, clear pelvic fractures. And I just didn't want to go low. And they were like, well, do you want to try putting in an ultrasound guided IV? And I was like, do you know my skill? Like this is going to take way, way longer. So I put in a bunch of humeral IOs and I love them. They worked really good as long as I think the difference, and you just don't know from a trial like this. And I can't imagine pre-hospital, I think it'd be a nightmare. If you get something and strap the patient's chest in that, just imagine they had a dislocated shoulder and you didn't want it to come out. If you wrap it hard so it can't move when you're moving to the CT scan, they stayed in. But if you let anybody move it, it was gone in a second. So that was my key. If you still want to use it, it's a good approach. I think everyone's afraid because it feels like there's more crap in that area, but there's not. It's just the exact same thing, just drill into the bone. But you got to strap that arm so it just does not move at all. I think that's the clinical key. But
there you go. You've taught me something right there. Yeah. Thank you very much. All right, let's go on to the next paper, which is, I believe, written by one of your colleagues. Is that right? Or partially?
Yeah, both of these docs. Kevin Schwartz is the infectious disease at my current hospital, and Maria Ivankovic is a longtime friend and colleague. And they wrote the Canadian journal or medical journal is. It has these like little short snippets where they're based on a systematic review or other things behind, but just like short clinical one pagers. And I thought this one was a brilliant one. Just five points about antibiotics. I'll just read them out. Antibiotic resistance is a major public health threat. I agree. Longer courses of antibiotics do not prevent resistance. I think that's the big myth that I think most of us have heard and we know by now. But I'll say in the same month that I copied and pasted and put this into our form, I saw multiple Instagram posts from the World Health Organization, the WHO, criticizing patients for not completing their full course of antibiotics, which is, I think maybe they're coming from a tuberculosis background or something like that, but like they weren't, that's not what they were talking about. Like, I don't know, but longer courses don't help. Almost all of our community acquired infection, when you look at UTI, when you look at pneumonia, every trial has shown that maybe even 3 days, but they say 5 to 7 days is enough. They have some exceptions. They say there's a few exceptions to that shorter is better rule. I actually don't know that that's true because the exceptions they use are things that I don't actually give antibiotics in at all. So like otitis media, they say will have a higher cure rate, but the cure rate is like there's less non-infected.
Yeah, it's a microbiological cure rate, not
it's like cure. It's just sort of like a who care. And so they conclude the shortest effective duration of antibiotics is best for patients in society, and I think that's true. And so for a lot of things, I still often write, like cellulitis is a tricky one because like you never know when that redness and stuff is going to go away. So I still often write for a slightly longer course, but I tell patients, if you're at 24 hours and it's clearly better or gone, just stop. Like you shouldn't be completing a course of antibiotics just because I wrote it for that long, because I'm guessing the number to write on that prescription. And I've really jumped on board with the kids in particular. My guess is we'll get down to like 3-day courses for pneumonia. But yeah, pneumonia, UTI, like the max I'm writing now is 5 days for almost all, except for like the complex, cancer patients or something like that. So I thought this was a nice, very, very short, like we're not getting deep into the science, so it's hard to critically appraise it, but I agree with the points and it was a friend. So why not include it was the thought, I guess.
No, completely. It's a nice, short, little, sharp, and it's well laid out one pager essentially. Which, once again, you could print out and leave on the tea room coffee table, and people could have a read in their break because it's a nice, easy one. I do like these points, and that's the way I've been practicing for the last 10 years or so. And I actually, in Australia, the pharmacists get very upset if you don't write the actual number of tablets, which is in a box. So, like, so amoxicillin comes in a box of 20. If you don't write 20, then they I think they'd probably just give the patient the box of 20 anyway, because like it's funded. That's the way it's funded. Like one box is the funding. So it's kind of frustrating. And so in my practice in Broome, we dispense most of the medicines directly from the emergency department. So it's quite nice. So you can just give people 6 tablets of whatever you want and say, that's all you need. And if you're not better at the end of this, come back. And I think that's a really nice point of short antibiotic courses is you can say, look, here's 3 days. Because I don't want someone with pneumonia struggling away for 7 days and not coming back because they think if I just keep taking the antibiotics, I'll get better. Like, I want to see them again. So that's useful. I think patients are pretty good as well. If you give them permission, and I tend to say, take these antibiotics. If you feel better, you can stop taking them. If you get side effects, you can stop taking them. And I think that's pretty good advice to give people in the modern era, because most of the things that we're treating, the patient's probably going to get better on their own after a day or two, like you say. So completing a course and giving yourself diarrhea is not helping most patients. So yeah, absolutely.
Man, your pharmacist would hate me. For a long time, I've been making the point to residents and students that like almost all the numbers we use are just made up, just because we have 5 fingers or there's 7 days in a week. So I very, very frequently write like antibiotics for 6 days, or like everyone's like freaks out. Or like when I'm doing a procedural sedation, very frequently I give 88 milligrams of propofol, and the nurses freak out. They're like, "What do you mean?" Like there's like these random doses that nobody else uses. It's just to show how arbitrary all of our numbers are. But yeah, I think your pharmacist would really, really dislike me.
I do have a colleague who's a little bit OCD. He's one of my anaesthetic colleagues, and whenever I relieve him for a tea break, I always turn the respiratory rate to 13. And then when he comes back from his tea break, he walks in, and I just love watching how long he can tolerate watching the ventilator going at 13 before he has to change the dial. It's hilarious. Anyway,
that's good.
I amuse myself. Cool. All right, let's talk about something that might actually make a difference. So this is a really interesting trial for the probabilisticians out there. So this is about the age-adjusted D-dimer, and so this paper is entitled "The Failure Rate of D-dimer Testing in Patients with High Clinical Probability of Pulmonary Embolism," and this is a reanalysis of some European trials that had looked at D-dimer, and they were the proper trial, the Modigliani, and the Tri-Speed trial. And essentially what they did is they looked at these trials, they retrospectively went back to the data set, and they've looked at the patients that were at a high pretest. I think that was a Wells over 6 or the Geneva score over, was it 10? I'm trying to remember now. So people who we traditionally would say, oh, this person's high enough risk that they should just go and have a CT or a VQ scan. They shouldn't have a D-dimer because it's not going to get them under the test threshold to say we can send them home safely. But they went back and looked at these big data sets and said, well, is that really true? And they looked at both the age-adjusted and the sort of absolute 500 nanogram cutoffs. And long story short is that they had a 0 miss rate of the patients that were potentially high risk and had a negative D-dimer. None of them turned out to have a PE, which is kind of reassuring. Obviously, this is tricky because this is not one nice, big, lovely, homogenous group of data. There's lots going on there, and we can't sort of do this. But it would be really interesting to see a prospective revalidation of the strategy and see how it goes. Because if we can use D-dimer in the more high-risk groups, and at the end of the day, all of these score systems are somewhat arbitrary in that what gets you a high risk in Wells, there's lots of different things that can get you in, and I'm more interested in the individual components that make you high risk rather than what the actual score was at the end of the day. And you can make any scoring system look high or low risk. A lot of subjective judgments in some of these as well. So it would be nice to see if this did pan out, but I think we need to wait for a bit more objective data before we go back to that. So, Justin, are you going to be age adjusting your D-dimers in your cancer patients with DVTs?
Yeah, I mean, you've got me in my brain on a different rant. I mean, people have heard my thoughts on decision rules, but I think the major reason in the future that decision rules will die is because we all use computers to calculate them anyway. So why lump all those variables together rather than having the actual likelihood of each individual one, which then would, exactly as you say, individualize it for your patient? Because it's a big difference on whether there's hemoptysis and a previous history of PE versus just happens to have a heart rate of 101 at triage. Like, those tell you different things. Right now,
Yeah.
they end up lumping those things together, and two very different patients can look identical based on the way we group them together. So yeah, long term, I think all of our decision rules should just go away because you should get individualized data. I guess like we've had things like that for a long time, but I don't use it. Like in GPs, use the Framingham risk calculators that like do a little bit more calculating behind the scene. But anyway, that's a different different topic. I threw this one in there. We've had a bit of a debate recently at my hospital about exactly, somebody's trying to put together a more standardized approach to PE. A whole nother debate on whether standardizing care is a good idea, and I'm not sure that I'm on board with it. But one of the parts of it was, in higher risk patients, can you use age adjusted cutoffs, or should you just, in the higher risk patients, use a set cutoff for D-dimer, or as we say, should we just go straight to CT scan? I've always been taught that you should go straight to CT scan in the people who are in the highest group of wells. And when I run the math, that seems to be correct. But that's based on, I can't find data exactly saying that. I can find a negative likelihood ratio. A D-dimer seems to have a negative likelihood ratio around 0.1, 0.15. And if you have a pretest probability between 30 and 40%, that 0.15 gets you down to a 5 to 10% risk. And obviously, we're not happy with, like, 5 to 10 is pretty high. I will note the 0% failure rate here had a 95% confidence interval that goes all the way up to 6.5%, which fits exactly with the math I just said, which is between 5 and 10%. So I think it still might be all correct. So unless somebody out there has data that says that D-dimers have a better negative likelihood ratio or can be used in high risk, I would really love to see it, because it would be really nice if D-dimers could be used across the board. And they're a very sensitive test, so it's possible, and this data sort of is a hint in that direction. To me, it's just too small a trial with a 95% confidence interval that goes that big to say, but it's reassuring, I think, that if age adjusted works even in the highest risk patients, that anytime that you use a D-dimer, you could probably use an age adjusted D-dimer. In fact, the way I phrase it is, anytime that I'm using a D-dimer, I use the highest cutoff for the D-dimer that I'm allowed to use. So that could be age adjusted, it could be years, it could be whatever it is, because the way the test works is just a highly sensitive test. But that's only when I think that a D-dimer is appropriate. So if a D-dimer is appropriate, highest cutoff I can use. Otherwise, in these really high-risk patients, I still go straight to CT scan. And that's the one I'm not sure that I could change my practice based just on this one trial, but would be interesting.
Yeah, I've just done a review of the Profundus trial, which was looking at included D-dimers for dissection, and they compared the standard sort of 500 nanogram cutoff versus the age adjusted, and it basically kept the sensitivity the same, and the specificity went up sort of 10%. So if it's going to save you a few CT scans, it's I think pretty much everyone should be age adjusting D-dimers nowadays, for both indications. So. The only other thing I'd say about this is European trials as well, and we know that the Europeans tend to have a ridiculously high baseline rule-in rate. So I think the patients that go into these trials are a lot higher risk than the average sort of American, Australian-based patients, which we tend to work up at ridiculously low risk rates. So I think if these guys in the European trials are saying they're getting down to a pretty low threshold, it's probably better in my context, or particularly in the American context. So
0% in Europe
maybe
is like probably equivalent to like 15%, or like negative 15%. Like you just can't get any better than that. So yeah, no, I was impressed. There was a reason I threw it in, because like this is a good data set, but I'm not really sure exactly how you end up using it to change practice right now, aside from hinting to people who do this kind of research that maybe we need a replication of this kind of trial. Yeah,
this would be an awesome trial for someone who's interested in this sort of stuff to do, and but you do need prospective data and close follow up, because as we know, these trials can be very biased in retrospect. So cool. Yep. All right.
I'm curious
Let's
about
move
this
on
one,
again to.
Casey. Like, I know you're an ultrasound nerd, and you nerds know everything, and especially ultrasound nerds who trained with and work with Dr. James Rippey, who might be like the biggest brain nerd on the entire planet. So you seem to know literally everything. So I'm assuming before I
Okay,
sent this
he's
paper to
probably
you,
listening to this.
yeah, you knew what Dietls was before I sent this paper to you. Is that a correct assumption as an ultrasound nerd?
Well, actually, it's interesting because I didn't know it was called Dietl syndrome, but I knew about this syndrome because this is something that we see.
Rippey,
This
you failed everybody. I don't know, man.
there is a bit of a trend in Australia away from eponyms,
Okay.
so we tend to go with we just call it PUJO because that's what it is. But this was a question on my ultrasound finals exam a couple of years ago when I sat my exam, because it's like differential diagnosis for essentially hydronephrosis without any stone. So and that's one of the big differentials. And so this is something I've known, but I just didn't know it was called Dietl syndrome. But thank you for sending it through to me, because then I went and looked up Dr. Dietl, who sounds like a pretty cool guy. He sounds like the Justin Morgenstern of the 19th century. He's a Polish/Austrian physician who was a bit of a Renaissance man, and also managed to describe a few things, including this syndrome, without an ultrasound, which is pretty impressive. And he also was one of the earliest proponents of evidence-based medicine, and actually did randomized trials with for looking at phlebotomy for the treatment of pneumonia, and tried to get rid of the idea of therapeutic phlebotomy for the treatment of pneumonia by doing randomized trials. So good on him.
I'm really interested. How the hell did he diagnose this without? So maybe this is why you think he's like me. Did all of his patients die, and he was doing autopsies on children and finding hydronephrosis? Like, how the hell do you diagnose this without imaging?
Well, I guess if you've ever seen any of these patients, but if you have this for long enough, you get a really big, massive, swollen up kidney. So they could probably detect it clinically. So it's probably palpable in a sort of malnourished sort of, Polish immigrant type.
I've never felt a kidney in my life. I do a lot of blood. I have no clue what it is, but all right, fair enough. That is good. Anyway, we haven't actually mentioned what the hell we're talking about. So we said this is a case report, or two case reports, in the Journal of Emergency Medicine from October 2024. The lead author was Thom. And basically it's two pediatric patients who had a provisional diagnosis of cyclic vomiting. So they were in the emergency department, were currently for the same thing. And ultimately these physicians did a bedside ultrasound, found hydronephrosis without a stone, and diagnosed this thing called Dietl's crisis. And I've been meaning to drop this something like this for a while. So I was excited to find this paper, despite the fact that it's just two case reports, because it was about 5 years ago when I called a urologist for this patient who was like, sick as heck, vomiting, and had this hydronephrosis. And he just looked at me. He's like, "This is Dietls. What are you talking about?" And I was like, "Yes, I totally understand what you're saying." At the same time. So apparently some circles just absolutely know this. But basically you get some chronic uretropelvic obstruction, and apparently even especially in kids overhydration, because that then cause some significant hydronephrosis, and then you get stuff that looks exactly like cyclic vomiting, pain. Imagine that you're having a stretch of your ureter. It makes perfect sense. And long term, a lot of these kids do require a surgical procedure, although conservative treatment seems to work pretty well as well. The thing I maybe find most fascinating about this paper is it just highlights how different things are in North America. Because I think we are way less test happy than they are south of the border. But there's just no way a kid or anybody. I've only seen this in adults. I haven't seen it in kids, but apparently it's way more common in kids. But there's no way you can get the diagnosis of cyclic vomiting and have multiple emergency department visits with zero imaging in North America. And that's what these kids in the UK were. Like, that blows my mind. And I understand if you're kids, you're not going to do a CT scan, but almost certainly in Canada, in an adult, you're going to catch this at some point incidentally, even if it wasn't on your differential diagnosis. At some point, you're just going to do the imaging. But I guess if you didn't know what the significance of the hydronephrosis, you could miss it. So I threw it in here because it's interesting. I don't know that this is an excuse for everybody to do bedside ultrasound. You can argue with me there. I feel like I can still trust my formal folks to do it just as well. But it's an interesting diagnosis to know of. And you could, again, if these kids are coming back over and over again, I think this is an important one, because you can, if you can treat it, you can save a lot of distress. Like, it's, the cyclic vomiting, we got nothing we can do, but this is like a treatable cause of cyclic vomiting potentially.
Yeah, it's good. about 1 in 500 antenatal ultrasounds done at that sort of 20-week anatomy scan have this syndrome on them. So it's not actually that rare, and it's actually diagnosed antenatally in most developed countries nowadays. So, like it's probably yet another pre-disease, as we were discussing before, that some of them don't go on to get the actual Dietl syndrome, but they just have this and their parents worry about it because they've been told that they have it now. So it's a tricky one. I think in terms of point of care ultrasound, this is a really easy diagnosis because, sometimes when we're looking at kidney stones, we're looking for really subtle hydronephrosis. This is not subtle hydronephrosis. If someone's had multiple episodes and they've come in vomiting, their renal pelvis is bigger than their kidney sometimes. So it's pretty easy to see. It's a big black thing sitting at the hilum. So it's not too hard to look at. And it's actually really uncommon to see that with patients with kidney stones because they've usually got sort of mild to moderate hydronephrosis, whereas this is pretty gross. So
it makes me feel good. It is. I as much as I make fun of bedside ultrasound, I definitely throw the ultrasound on these people, assuming I can find it and it's plugged in and charged, and this is just one of those things. I don't think if you're actually running a workflow and you're thinking about how much you pay the physician versus the tech and what I could be seeing other patients, sure, I don't actually think that it's a worthwhile use of my time, but it's really good to walk up to a patient and be like, I know the exact cause of your symptoms and I can make you feel better. So I still do it occasionally, but if the department's really busy, I think spending 5 or 10 minutes to actually get the machine to reboot because it wasn't plugged in, or clean it because the person before me didn't clean it, all those kind of things. In your setting, I know you have the part you have a room dedicated to ultrasound, and it's got aura and glow and Rippy will hit somebody with a yardstick if they don't clean up the machine after them or whatever happens in the department. Yeah, sure. It's not a problem. And if you're there, literally you have nothing else to do that day except for do ultrasounds. But in a busy spot, I still think that the bedside ultrasound crew has probably pushed too far the use. I think most scans that aren't life-threatening scans, give me a cardiac scan in a resuscitation patient or that rush protocol in a critically ill patient, man, ultrasound is really, really important. But screw around with testicular ultrasound or renal. I feel like I have techs for a reason most of the time. But anyway, maybe I'm bringing the argument too far, too close to home.
No, I think that's completely reasonable, and it depends on how your system's set up. And my only real defense is that I'm going to say that it's fun, Justin. That's my defense.
It is fun. I maybe shot myself in the foot right there because most people can't get 24 hours. So the testicular one is a really bad example, actually, because at 2 a.m., if you really want to know what the hell's going on, or if you're rural and the closest ultrasound is I got to call somebody in from 8 hours away or whatever, there are definitely rules for it. But I think you just got to be cautious about and knowledgeable about your own system. And I feel like anything, people who do it all the time are going to push it a little bit more than is 100% necessary. But anyway, I think that's a long way from what the point of this paper was. And I don't know, it's 2 case reports, so I'm not really sure what the point of the paper was. But I just wanted to give the idea of Dietl. Maybe somebody learned something.
I think that it's way commoner than people think, and it's probably under-recognized and misdiagnosed as renal colic, probably for a couple of visits. It's kind of like the AAA or of the kidney side, and it's just something that people miss because they're not aware of it more than anything else. So yeah, just raising awareness is good. Yep. And you look really smart if you call it out with a German accent. Cool. All right. Now, for those of you who are first-time listeners, you know that Justin may be completely obsessed with wound care in the emergency department. I think he's written 7 million words on his blog posts.
It's not wound care. I'm just obsessed with PubMed. So once I start on a topic, yes, I have at least 8 different articles on the evidence for wound care at some point. But yes, once I get on a topic, it just never stops, unfortunately. I can't help it.
And so we're going to be discussing this trial, which is possibly the smallest budget trial of the week, I think, of the month. Yeah. So this is a randomized controlled comparison of Guardian perceived cosmetic outcome for simple lacerations repaired with either Dermabond, Steri-Strips, or absorbable sutures. This is Pediatric Emergency Care, August 2024, and the lead author is Barton. And so essentially they only had 55 kids, and I think even fewer once they got the loss to follow up. So they randomized them to 3 groups to either have Dermabond, skin glue, Steri-Strips, or absorbable sutures. And then, long story short, if you want to get to the bottom line of all of Justin's write-ups about this, is it really doesn't matter what you use to close wounds because they all work out exactly the same. But in this very small cohort, Dermabond looked maybe a little bit better. It was sort of at that sort of threshold of superiority, I guess you'd say, in that it was almost 15 points on the visual scale better. It's also a lot quicker and a lot easier for most kids. So I'm a fan of Dermabond. A few things I didn't like about this trial: they specifically excluded kids with lax on their scalp, which is, I'm sorry, that's like 90% of the lacerations I do as toddlers that run into coffee tables. So, like, I can't really apply this to this cohort, but I'm going to continue using Dermabond on toddlers' heads. Justin,
No,
am I wrong for doing that?
Having read everything, I think this trial adds exactly zero. Like they included just the wrong patient. So I think the median length here was 1.5 centimeters, but you couldn't be any longer than 5 centimeters. You couldn't have more than a 5 millimeter gap. You couldn't be more than 12 hours old. So these are the most piddly of piddly lacerations. I am almost certain that a Band-Aid is enough in every single laceration that they covered here. And so you didn't need to do anything, which means that, this trial doesn't add a lot. But it's just one of many saying the exact same thing. Although this one, as you say, actually the point estimate's not just for like the visual. I doubt that the scar could be any different, but it does look a little bit better with Dermabond. But everything else, pain, length of stay, overall satisfaction, they're all not statistical because there's 55 patients, but all look worse with sutures, which makes sense. Needles suck. The freezing sucks. Or if you're going to like anesthetize it with topical stuff, you're going to be there for an hour and a half to get it done properly. It's just mostly here for me to give a pitch. I abandoned sutures almost exclusively a couple of years ago after doing this. And there's one, if you have active bleeding, if you got to do some deep ligation of things, if it's a real mess, there are times for sutures. But I would say between 95 and maybe even higher, 98% of everything I see, it's Dermabond and steri strips, and I don't need anything more than that. And I think people should give it a try. I think patients will be happier. There's less pain. The amount of time is I see people who pick up a chart and they're like, oh, laceration, because I don't know, it's going to take you 20 minutes. I'm in and out of the room in 90 seconds. I think for almost everything, this is the way to go. And actually, I think I would love to see it studied, but you're getting a perfect seal over top of the wound as compared to point closure where the wound is still open. So things like bathing and in long term, it feels like infection rates should actually be lower because nothing can get in there now. It's go jump in the pool, go. I don't. That's all the instructions I'm giving. Let me be clear, but it just seems for bathing, for everything else, in the days of using alcohol hand sanitizer, for all of it, when I cut myself at work, you don't want alcohol getting in there, so you seal it all the way. So I'm a big fan of Dermabond. I use it for basically everything.
Yeah. If only there was a cheaper version. You could probably just go down to your local hardware store and get whatever cyanoacrylic glue is on the shelf and just stock that in your ED, because it's bloody expensive still. But it is what it is. So
Yeah, I mean, I know people do that in construction. I need to fact check this at some point because maybe it's a myth, but my understanding is they had to tweak the chemistry a little bit. I mean, it gets hot, it burns a little bit, but I believe the original super glue actually gets to a temperature high enough that it can cause skin burns, and that's why there's basically one sodium changed at one point in the molecule, so it basically is super glue, but it gets a little bit less hot when it polymerizes, I believe. But that's, I think, word of mouth. I don't know that I've actually fact checked that.
There you go. Some chemistry from Dr. Morgenstern. There you go. Cool. All right. Shall we move on to another kiddie topic?
So I put this one in here to prove that I love the PECARN network, despite some harsh words that I sometimes have for decision rules. I had to dig back a little bit. This is back from 2018, but the PECARN puts out so much stuff. We could cover them every single month. But this is an RCT, a double-blind RCT, a very good trial that basically asks the question, in young kids with gastroenteritis, does using probiotics help? And specifically, it's Lactobacillus rhamnosus, I think 1 × 10 to the 10 colony forming units twice a day for 5 days, or a matching placebo, and negative trial. There was no difference in outcomes. I think it's this is one of those ones that comes up every once in a while. It's more of a parent question. I don't think that residents are rushing to prescribe probiotics most of the time, but I get asked a lot, and so it's nice to know. I find the whole topic really, really interesting. And unlike some alternative medicines that have a 0% chance of ever working, I mean, this, it makes sense. And there's a lot, the microbiome is complex, but our current approach, just having you swallow and having the stomach acid deal with a bunch of bacteria that are then clearly going to be dead before they get into the intestine. And even if they make it to the intestine, there's so many bacteria there already, they're not going to take up home. The whole current approach doesn't make sense. So I think there's a lot of basic science that is needed before we just start throwing bacteria into people's bodies and hoping that it works. So I threw it in there. I don't know why, because I think it's interesting to see a negative trial. I think people might ask you about it, but also as a long-term thought process to think about, like, how would you actually get the whole microbiome to work in our favor? Because I think it is an underexplored area. Right now it's in the woo. Like, people who talk about the microbiome are woo practitioners, but I think it's something that we don't, as practitioners, really grasp about the human body. We know it has a major dramatic role across the animal kingdom, and I just don't know that we have any way of harnessing that in medicine yet. And so it's an interesting topic, in my mind at least.
Yeah, absolutely. Like, but before Barry Marshall discovered Helicobacter pylori, we didn't understand how all that worked, and so I'm sure there's a lot of amazing interactions that go on in a very complicated web of microbiology in our gut, and maybe it does have something to do. But yeah, as you say, science, that's not how science works. You can't just sort of change things and hope it works. So we do need to get some primary science happening on that. This is a good trial. I think in my sphere, this is not something that comes up very often in the emergency department, but one of my hobbies is standing in the local pharmacy and listening to the advice that gets dealt out by the pharmacist when people take their prescription in for Dr. Morgenstern's 7.3 capsules of antibiotics that is prescribed. It's a hard sell, and a lot of the commercial pharmacists or private pharmacists will try and sell a whole heap of stuff that goes along with the antibiotics, and this is one of the things, probiotics. So maybe I'll add that to my pitch when I'm telling patients what to do with their antibiotics is, take them and stop taking them if you get side effects, and don't buy anything else that you think is going to help with those side effects, because it's not going to help. So it doesn't help these kids with gastro, so it's almost certainly not going to help kids that don't yet have gastro problems. So
yeah, you can give the exact same advice on our last paper with a number of like scar creams and stuff like that, and that's even more expensive than probiotics. So yeah, in general, unfortunately, there's still a lot of crap out there, and I think the North American model is a lot worse. I've been in pharmacies in Australia, and they're not nearly as commercial as here. But like, yeah, when you walk up and down our aisles, like 95% of the things that you can buy in this healthcare setting are just crap, and it's really actually hard. I don't remember if I ever actually posted it on the website, but I went around to a couple of pharmacies one time taking pictures, and the like homeopathic thing that has zero medicine in it, they designed the packages to look identical to the real medicine, and the pharmacist puts them on the shelf next to each other, and the homeopathic one always costs 50 cents less than the real medicine, but they otherwise, I have a hard time, I had to like read into the fine print, so everybody buys the freaking salt water and leaves the real medicine on the shelf because of the 50-cent difference. It drives me nuts. It's so bad. I'm not sure I warned you.
Side effects.
And we might have to pause for a second. It's toddler going to school time. I'm not sure if you can hear in the background this screaming, but give me 1 second to just check and see if there's help needed. I'll be right back. We'll just pause the podcast for a second, okay?
No worries. All right. After a brief toddler-related pause, Justin, sorry for your life. It sounds like you'd like to admit that you were wrong about something, and I'm just going to open the floor up and say, Justin, would you like to confess your ignorance about something?
I mean, I really, really try to find things that I'm wrong about every year, because otherwise, like, how do you know that you're learning or getting better? But when it's the most mild stuff, I feel like maybe I'm cheating my system a little bit. But yeah, this over the years, honestly, I may have been a little bit critical of colleagues in my brain at least, but I thought I noticed among bounce backs, a lot of kidney stone patients who bounce back all seem to have a prescription for pick your opioid, but they never had an NSAID on there, which is weird to me because all the literature says that NSAIDs are like dramatically the best treatment for renal colic, at least in that acute phase when you first come in. And everybody uses ketorolac or something as first line NSAIDs, and then they don't seem to send them home on it, or at least regularly. So I've had naproxen as part of my like home prescription for years. And the part where it looks like I'm wrong, I don't think there's anything wrong with using NSAIDs in kidney stones, but I just assumed, people not having had one myself, I just assumed that you would have pain for the next 5 or 7 days or 3 or 5 days, something like that with the kidney stone. So rather than giving the naproxen as a PRN, as an as-needed medication, I just figured, why not use naproxen twice a day for 3, 5, 7 days, something like that. Because part of the kidney stone is like once you start having that pain, like you start vomiting, you can't take the oral medications at home. And I sort of assumed that would help prevent people from having to come back from the hospital. And maybe it was judgmental of my colleagues who kept having all these bounce backs, and I never saw my own bounce backs. You know how it is. This is. It turns out, it looks like I am potentially wrong. This is an RCT out of Tunisia, which you don't see that many RCTs out of Tunisia for emergency departments. Took people who were clinically diagnosed with renal colic and randomized them to 3 groups, either piroxicam, which is an NSAID, not one I use very often, but piroxicam, paracetamol, or placebo, to be taken regularly for 5 days, exactly like I was describing, to try to prevent the pain. It's almost 1,400 patients, and they were looking at the rate of recurrence of the renal colic pain. The numbers aren't like great, but about 30% of each group had recurrence of their pain based on a phone call. About 20% of each group came back to the emergency department, which is a lot higher than I'm used to. And the big thing is that I think clinically speaking, most people with renal colic don't need any imaging at all. If you have a history of it and you're like, this is my renal colic, unless there's something on the differential diagnosis, I preach all the time. You definitely don't need CT scan on everybody. You can tell me that I should be doing a bedside ultrasound on everybody, but like for the most part, we can do no imaging at all. But in a trial setting, that is a little bit more problematic because who knows what these patients actually have. Maybe we're treating Dietls in all of these patients and we don't know what it is. And then the other big problem with this patient is that they didn't ask them, like, so we know that 30% of each group had pain coming back, but they didn't ask them how much pain they are. So maybe they like one group had 5 out of 10 pain and the other group had 10 out of 10 pain. But my big problem is that they didn't ask about like home meds. They ask everybody don't take over-the-counter medications, but they didn't ask them if they actually had taken it. So it's quite possible that the placebo group was sitting there popping, Tylenol 3s or codeine or something like that at home, and the NSAID group wasn't, and we just wouldn't know from this data. So it's not like it's a perfect trial, but the idea of giving regularly scheduled NSAIDs does not seem, based on the best data. I've never seen a preventative trial in renal colic before. So kudos to these authors. Like it's a big 1,400 patients RCT. And I've never seen this question asked before. So it's really, really nice trial to have. And it doesn't seem like the regularly scheduled NSAIDs made a difference here, unfortunately.
Cool. Yeah, no, it sort of makes sense. In my experience, and maybe I'm just a bit biased, but renal colic by its nature is colic, and you tend to get a bad episode, and then we treat them in the ED, and the stone moves or it partially unobstructs or whatever, and then they're fine. We send them home, and the ones that come back, presumably the stone moves into another spot where it's obstructing and causing pressure, and then they get pain again. So I don't imagine that NSAIDs actually help that. Whereas if you've got an inflammatory problem, maybe you're more likely to get benefit from that regular NSAID. So in my head, the pathophysiology doesn't really lend itself to prophylaxis as much as
it's true. But
maybe
what do you do when they bounce back to the emergency department? What do you do to treat their pain? The only thing I do is give them some NSAIDs, and they feel better and they go home. So, I don't know.
That is true, but having said that, but maybe they're having 3 or 4 doses of the NSAID before they get the recurrence, which they didn't really need. So it's kind of like your argument for
100%.
It's kind of like your argument for otitis media, giving them a walking script. Yep. So I think that's okay. To be honest, I tend to discharge people with whatever it was that worked for them in the ED. So like if they had a dose of celecoxib and that didn't work, and they got some paracetamol that didn't work, and then someone gave them a shot of buprenorphine sublingually and that worked for them, then I just sort of say, here's one of these, take it home. Because when they come back to the ED, that's probably what they're going to get again. I don't give them a script for 20 tablets. I just say, this is your own home management kit if it happens again. And if this isn't working, you need to come back and see us, because that would be an indication for possibly doing an intervention or getting a CT or whatever if you're having recurrence and you're getting sicker. So I think that's reasonable. I don't think it's going to change much practice. I think most people that I know take their own over-the-counter NSAIDs in my part of the world. So I probably just tell them to have some ibuprofen at home and swallow that, because I definitely don't think there's much difference between the various NSAIDs for this indication. So crack on and do it. I think empowering patients is a reasonable thing to do. The bounce back rates, I don't know, like it's 1 in 5. It does seem reasonably high. I agree. I don't know if that's just a local culture thing where sometimes people maybe are more likely to bounce back. But it is a bit tricky to say how many of these people actually had renal colic if they didn't get any imaging. So a good proportion of them are going to have something else going on, in my estimation.
I think everything you said is correct. I think there's one thing that may be subtle points and maybe a cultural thing. I'm not sure. It is true. Everybody has over-the-counter ibuprofen at home in Canada as well. But I find when I ask on bounce back patients in particular, hey, what did you take to try to prevent coming back? They always took what was prescribed to them and never took the over-the-counter. And I think the strength of the recommendation on a prescription is very, very strong.
Sure.
And people get the idea. I think in the doctor's brain, I'm prescribing you morphine, but assuming that you're going to take ibuprofen and then morphine as a backup plan or something like that. Whereas in the patient's head, it's like he prescribed me morphine, so that must be the right medicine. But we have tons of data knowing that NSAIDs are the best medication. So I think the act of putting it on a prescription, even if you're just prescribing ibuprofen, is strong. Or you just have to have a really good discharge instructions being like, look, ibuprofen, it's weird. Yeah. I know it's not the strongest thing for like your ankle sprain, but it is like, for whatever reason, it is the best here. And this is your backup medicine on the prescription. I think that's really important. I think a lot of people just get that message incorrectly. So I think it's a subtle style point, or maybe it's just different patients, a cultural point, but emphasizing that the NSAIDs actually really are important here. I think we know that they're important, and that doesn't always get across to our patients.
Yeah, we can harness the placebo effect and write the ibuprofen on a script pad. That would be probably the way to go.
I prescribe a lot of naproxen. Naproxen is over the counter in Canada, but I think it is very beneficial, both from an instruction standpoint. But I do think that prescription helps. I could be wrong, but we're talking about it in a paper where I think I've been proven wrong. But I think there's some benefit of those written instructions. Although I'm not very good at written instructions for other things for patients as well, but I don't know. I think about it as a valuable added, you can write out the order. If I write a big number 1 next to the naproxen and number 2 next to the morphine, I think that helps people understand what my thought process was. If I'm not very good at, anyone listening to us knows that I'm not very good at verbalizing anything that's in my brain. So God help my patients.
Well, actually, one thing that we are doing a bit and starting to roll out in Australia is these e-prescriptions, and the patient actually gets like a text message that has like the discharge instructions on it, which is like, that's how people think now. So no one, if you give them a piece of paper, they could lose it and they leave it in the boot of their car or whatever, but no one loses their mobile phone and they can always scroll through their text and find it again. So I think that's the way of the future. So let's do that. That'll be good.
Yeah, we just rolled out a brand new EMR, but everything has to be printed for the patients. I don't understand it. We raised that exact question. Like, why don't they just get a text with that same information? And that way, our nurses have to go and find a printer that's actually working and find paper and give it to the patients. Like, it's so dumb. Anyway, that's a different rant altogether. Yeah, I think there's a lot of benefit for that in the future.
Sounds like some things are universal.
Yeah.
The printers, yeah. All right, I think we're up to our last paper, and this is clearly the paper that everyone's been holding their breath for, because we're finishing on a strong note. And
I honestly, I think you're joking right now, but I think this is the best and most interesting paper that we've covered in a decade of doing this podcast. Like, this blew my mind, man.
I love this paper. I'm a big fan of the evolutionary biology podcasts. Like, there's 2 or 3 really good ones out there, and this is the sort of paper which I just love when they present stuff like this. So I'm glad that we can sort of pretend it's vaguely medical and just talk nerdy about some biology, because it's much better than
I think so. We'll jump in, but I think this pretty definitively proves that ants are better doctors than at least Dr. Casey Parker. I don't know. There may be doctors, but the outcomes here are incredible. So this is Current Biology by Frank et al. Wound-dependent leg amputations in combat infections in an ant society. I freaking love this paper. It's there's just so many parts to it, and I'm not sure that again, this is one of those ones that I read back in September, so I'm not sure I can summarize all, because it's outside of medicine, people always do multiple studies within one paper, and so it's a series of studies. But my brief summary of this would be that in ants. So in this particular species of ants, they lost one evolutionarily lost one of the antimicrobial like chemicals that you have, and so these researchers were wondering how they stay alive.
The metaplurogland.
I'm glad you had that at the top of your head. So you are the better doctor of the two of us. We knew that already.
No, maybe the better biologist, I think.
And so what it turns out, there's two ways that ants will treat wounds to their legs. Either they'll just do wound care, which is licking of the wound. We can discuss whether that would work in humans or not. Or they do an amputation. And apparently ants are very good at knowing. So if you have a wound to your lower leg, apparently, and this is weird to me, the circulation is better in the lower leg than it is in the femur for whatever reason. And so infections spread faster from the lower leg. And so amputating doesn't work in the lower leg infections, but amputating does work in the higher leg infections. And the ants apparently know this, because if you have a femur wound, they will amputate essentially all the time, but they never amputate a lower leg wound. And you might think, oh, whatever, ants are just doing whatever. But the success rate, when they artificially infect these wounds, and the way they did it is, so they infect these wounds and they did a surgical amputation, so the researchers did the amputation themselves, or they just took the ant where they put the wound and put it back in with its colony mates, or they put it all by itself, so it couldn't get the care that it would normally get. And if you put Pseudomonas on this wound and put it back with its other ants, the ants will do the amputation. And like the survival rate is basically 100%. And I actually think I wrote the numbers down here wrong because there's like so many studies in here. But like if you take the ant and put it separately, the mortality is like above 50%. It depends on which part of the study that you're doing it. So like they have a number needed to treat approaching like 1, 2. Like they saved everybody's life by chewing off legs. Like this is to me just like I don't know what else you can add to that, but like it is astounding how good this ant medicine is when you read through this paper. Like it is astounding. Am I overly excited?
It is really good. No. I love this paper. It's really cool. So the species of ants that they were doing, they're called Camptonotus, which is the carpenter ants, and they're the ones that don't have this gland. So their only option is to amputate. And then they also talk about this other genera, which is the Megaponera ants, which still have the medicine. And I like to think of them as the internal medicine doctors, who all they've got is drugs. They can't do an operation, so all they've got is licking, and they have antimicrobial secretions in their saliva, which they can put on wounds. Whereas this group of ants are clearly the orthopedically or vascular surgery inclined, and they just come along and lop limbs off, and hey, it works pretty well. So. Yep. Go for it. So it's very interesting. Do you think that means that surgeons are more higher evolved and that they've lost these vestigial antimicrobial glands? I don't know. That's interesting. Fascinating.
I think you're just trying to
maybe I've pushed that metaphor too far.
And an anesthetist. I think you're trying to gain some points.
It is really fascinating, and I did like your other point. If for no other reason, you need to look at this paper, scroll down to which image is it? Oh, it's Figure 4, where they actually show CT scans of the ant's legs at various slices through the tibia and the femoral part of the leg, and they can actually do CT scans on things that are literally like a millimeter across. I think their surface. Was it 70 micrometers was the gauge that they used to measure this? So, like, we're doing CTs with like 3 millimeter slices, and these guys are CTing things down to micrometers. Where is that CT? Honestly, why can't I have it?
It shows how we have trouble interpreting. Like you get a bad CT angiogram, and the read is something like I can't tell, but the vessels that they're looking at are bigger than the entire ant. But I think people need to look up the images in the trial. But like they can actually see the lymph system within the leg of the ant down to the detail is better than RCTs. And these are the thing that really drives me nuts, because if you'd asked me before looking at this paper, can we do CT scans in ants who have exoskeletons, and so the bone goes all the way around the outside, like I would have said, no, this is crazy, like this is better than we do it. And I'm assuming it's because A, we're killing these ants, and B, you probably get really good CT scans if you just use a crap ton of radiation. And so it's just like probably the dose is just not compatible with human life would be my guess. But I found this paper fascinating I struggle. When I put things in here, even when they're ridiculous papers, I like to have a clinical take home, and I'm not sure that there is one. I don't think our orthopedic surgeons are going to be chewing off legs anytime soon. But honestly, if they had a survival rate of 100% with amputations where they just chew people's legs off, it'd be good.
Diabetic foot infections. Go on.
Yeah, just get in there. But I think if we don't have a clinical take home, I think a little bit of humility. Like, we think of animals as animals, and ants, I would have put, like, if you told me that a bonobo has a system of medicine, I'd be like, yeah, okay, that's interesting. But like, this is not a subtle system of medicine. Like, this is advanced medicine, and I think that we underestimate the world, or maybe we don't underestimate the plant and animal world. Maybe we overestimate ourselves. And actually, when I look around at America and other parts of the world, maybe that's very clear, is that we have been overestimating human intelligence for a very long time. I'm sorry, America, but you've done it to yourselves. I think maybe that is the thing, but we are much, much closer to animals than we need. But, we're not going to be able to improve our intelligence, but I think there's probably a lot that we can learn from other folks, which is I don't know. This is just one of the, basic science. Like, if you're not curious, if you're not excited by this paper, I don't know, I can't help you. But this is like just fascinating to me that ants somehow figured out that amputations work and they can distinguish. Like, it's so good. Every time I read it, I pick out more details on just how good this medicine is. It's fantastic.
Yeah, different types of intelligence are definitely a thing. I've just been reading a book about octopus intelligence, and octopi have 8 brains, and they only live for less than a year, so they have no way of learning anything, but can solve all these amazing puzzles and everything. So it's just a different type of intelligence.
I sort of wish you would bring up that example. That's my biggest struggle, because octopus is still one of my favorite foods, but I really do not think that I should. I'm sure your kids would have some philosophical or ethical answers for me, but it's going to have to change sometime soon, because I think they are far, far too intelligent for how tasty they are.
Anyway, Justin, I think the clinical take-home from this is that if we get one of these micro CT scanners, we can diagnose PEs that are literally like 3 red cells clumped together and put them all on a pixie gun.
That'd be real good, yeah.
Maybe not. I think we should leave it there.
So anybody who's new to the podcast, you realize that at least 90% of the stuff we say is completely irrelevant, but hopefully, I don't know, somewhere in there, Dietls or something else, you got something clinical that you can take to your podcast. Otherwise, at least we were better than an Ambien for putting you to sleep. Maybe that's what we're aiming for. Slightly better. Sorry. Non-inferior to Ambien. That's all I'm looking for, and I will be happy.
That's right. Well, maybe our New Year's resolution should be to improve our game, so we can come back in January refreshed with a whole new batch of amazing papers and hopefully teach our audience something new.
I'm excited for the night. There is already basically done. I'll email it to you soon. I already got at least 8 papers to talk about, and there's some good stuff in there. So yeah, come back in the new year and we'll talk some more nerdy nothingness. Maybe we should read it. That's a good name for a podcast. Nerdy nothingness is, I think, basically what we got. We're good.
Are you being nihilistic again? All right.
Pleasure talking to you, mate.